I will show you how we go about it. So now I have introduced the scope, patient is sedated. What you are seeing is the tongue. This is the tongue. As I am going millimeter by millimeter, you will see the tongue, base of the tongue. So I will show you. Freeze, freeze, Pakudo. So now here, this is the base of the tongue, and this is the posterior pharyngeal wall. You can see this. Very often, because the scope is a little stiff, you will get stuck here, and it is difficult to go down, especially in patients who have a short neck or who are little obese. So concentrate on this air. I will show you how we do it. Open. So see there, I am here, then I start going downwards. I am just following the air, and you see corresponding endoscopy picture. I have smoothly gone in. I go in here, I am sucking constantly. I come till I start seeing the arytenoid cartilage on EUS. So you see here, freeze. This is the arytenoid cartilage here. So that means I am ready to enter the cricopharynx. Freeze, release. So once you see this, all you have to do is gently push, and you can see the cricopharynx actually here. I am gently going in, and at times you may have a little resistance, but most of the times you will easily go through. So we are in now, and I am rotating my scope clockwise, anti-clockwise to see where I am. This is the spine. You see this, freeze. So this is the spine here, and so we have to look anti-clockwise. Chudo. So I'm turning clockwise, anti-clockwise. It's good idea to spend some time here. Usually when you turn anti-clockwise, you will see the big vessels. So this is the aorta. So I have just done a little anti-clockwise, and then if I turn clockwise, I'll see the common carotid coming out of it. Freeze. So this is the common carotid artery. Here, this is the common carotid artery. Chudo. See this? This is the common carotid artery which is joining the aorta. I am still looking anti-clockwise. I am trying to see the arch of the aorta. So little anti-clockwise, freeze, and you will see there is another large vessel coming here. See this? This is the left pulmonary artery. So you are seeing the aorta, you are seeing the left pulmonary artery which actually crosses the aorta here. So this area will be the AP window, and if you are lucky, and then you will see the AP window. See this? This is the pulmonary artery. See this? Freeze. So this is the pulmonary artery, this is the aorta, and this is the AP window. So exactly you can make out the station 6 and station 5, and station 4 will be near the trachea. So here you are seeing the pulmonary artery crossing the aorta. Chodo. So once we see this here very nicely, you can see the arch. The traditional methods of AP window I find are very inconvenient to the patient. This one doesn't put any pressure on the trachea, and you can very easily visualize the entire area of the AP window without any problem. Just turn anti-clockwise. Now I have turned little clockwise and I am seeing the trachea. See this? This is the trachea, and I go down little bit and I start seeing the subcarinal space. You can see lymph nodes there in the subcarinal space. Freeze. So these are elongated lymph nodes in the subcarinal space. They don't look significant to me. Once we finish this, what I do is I try to get a tubular view of the esophagus. Now for that you have to do your up knob down and bada karo. What you will see, freeze, is two layers of the esophagus. So you have this one layer, this is the muscularis propria, and there is another layer on the other side. So you are getting a tubular view of the esophagus. See here, you will see a tubular long view of the esophagus. Traditionally, we have been taught mediastinal EUS where we mostly bother about the vessels. I think our aim in doing mediastinal EUS is to look at the esophageal wall and to look at the periesophageal space. So this is a tubular view of the esophagus where I am trying to see if their wall has any abnormalities. Doppler, if there are any vessels here, we will pick up the vessels also. उसका मुंह थोड़ा ठीक करो, घुमाओ ना Doppler. Yeah. So as you can see, there is air. I have not used a balloon. बंद कर दो. So I have not used a balloon here, but I think I am getting good information here. The esophageal wall looks normal. I am gently going down. See here, and now I am approaching the cardia. So you know that you are approaching the cardia when you start seeing the fundus. So here, see this, you can see beautifully the esophageal wall, and then you are going down and you are seeing the fundus. So this view gives me a wonderful evaluation of the GE junction. So if you can freeze, see here, this is the fundus and this is the layer pattern at the GE junction. You can beautifully see all the layers. So even a small lesion you will not miss. So this is a very simple thing. Just put your scope tip down. So this is the GE junction. And how do I know this is GE junction? Freeze. You see that is the diaphragm coming from that side. See this muscle? This is the diaphragm. So I am exactly at the GE junction. At this point, I would like to see if there are any vessels here. Doppler. Gumao. So any collaterals in the esophagus, periesophageal, doesn't look like there is anything major. So this is a sagittal view of the GE junction and the esophagus, and I have been using it now for more than a year, and I find it pretty useful compared to the traditional teaching. So once you are into the stomach, all you have to do is suck the air and water. So you see, this is the stomach folds. I am turning anti-clockwise now. So you are seeing the fluid in the fundus. See this? You can nicely evaluate the fundus for any submucosal or mucosal lesion. And after that, I have done this, I turn clockwise to look at the liver. So I go all the way till the tip of the left lobe. So you can see there, that is the tip of the left lobe, and look at the echo-texture of the liver, look at the vessels, look whether intrahepatic biliary radicals are dilated, and then freeze. Look at this long vein. This is a long vein which is traversing from right to left. This is the left hepatic vein. It divides the left lobe into segment 2 and segment 3. It is very important for therapeutic EUS for biliary drainage. So you should be able to identify segment 2 and segment 3 based on left hepatic vein. So this is the left hepatic vein. This liver looks nice. I think the echo texture is pretty fine. I start turning clockwise here and you will see the ligamentum teres. See, this is the ligamentum teres with the left portal vein here. Gently withdrawing with clockwise rotation. Gently withdrawing with clockwise rotation. See here. This is clockwise, and now you see the caudate lobe, freeze. This is the caudate lobe, segment 1. Behind that will be the segment 4 and 5. Children? Yeah. You can also look at the hepatic veins and the IVC. This is the IVC. Now I am extreme clockwise, and you see these are the hepatic veins. This is good for portal pressure measurement. You can measure into the hepatic vein and the portal vein. Very easy, not a big problem. So this is the evaluation of liver. We can also do shear wave elastography with this new machine. So if you are suspecting that the echo texture is not normal, then you can do a shear wave study here. So very simple, flip of a button and then you have this square box which comes in. Keep it at least 2 centimeters inside and press the button, and then it gives you a reading. Like that you take 3, 4, 5 readings from different areas, and you can take up to 10 readings also, but here just for example I will show you how it looks. You look at 3, 4 readings and then show the table. So in the end what comes is something like this. Show the table. Yeah, see here you will see the KPA. So the KPA of the third one is outlier, it is 16. We will leave that, but the other KPA is 7.6. You can also see the IQR and the depth at which the picture was taken. So if you take 10 readings like this, if you see the median KPA here is 7.85. So it looks quite okay. So this is an additional thing. Very quickly you can find out if the liver is abnormal. So shear wave elastography. Band kar do. So once we have done this, looked at the hepatic veins, liver surface, I concentrate on the hilum. So turn clockwise. See, I am looking at the hilum now, and you are looking at 2 structures. Please. So you have the portal vein here entering the hilum, and here you see the bile duct. This is the thin common bile duct. Sure. Looks normal to me, but we will see how it is. So bring that at about 6 o'clock horizontal direction. Look at the hepatic artery, freeze. So this is the hepatic artery here. So we have seen the hepatic artery, portal vein and the bile duct. Chodo. Freeze. So you can measure the bile duct to see whether there is any obstruction here. It doesn't look like, it looks like pretty normal. So this is 4.2 millimeters, pretty normal bile duct. So we have seen so far a normal liver, normal bile duct, and see this is the bile duct. So you will have to use a little bit of, if you see my right hand, I am doing what is called an exploratory movements. Clockwise, anti-clockwise, clockwise, anti-clockwise, and then focus on what you are interested in. Okay, so this is the evaluation of the bile duct and CHD. Now we trace it down. So I am going inside millimeter by millimeter. See, like this, turning little clockwise. The picture is becoming a bit hazy. See this? This is the pancreas. It looks very heterogeneous. We'll see whether we can get a better picture. So needs a little bit of, so now you are seeing the SMV and the SMA freeze. So we are in the region of the head of the pancreas. This is the SMV, this is the SMA. Chudo. And this air filled area freeze is the duodenal bulb. See here, this is the duodenal bulb here. So the pancreas is, head of the pancreas is somewhere here. The liver is here, bile duct comes from here like this, and then you will see the pancreas. Chodo. So this is the portal vein. We come back, see the pancreas. It looks very abnormal to me. Now, if you see carefully, freeze, below the pancreas is the IVC. This is the IVC. This is the head of the pancreas. This is the IVC. The IVC is forming the bed of the head of the pancreas. See this head of the pancreas? We are seeing lots of shadows. So that means there are some micro calcifications within the pancreas. So you have to spend some time here like this and look at the echo texture. It is grossly abnormal. According to me, this is a classic chronic pancreatitis. You see dots, strands, micro calcifications, and pancreatitis is not a great thing when you are doing EUS. You will not get very great images, but you can have a decent idea. So this is what is happening in the head. I don't see a mass. I am seeing chronic pancreatitis changes. Now if I have seen that, then I want to see the body and tail. That is a standard maneuver, you know that. So you see above the SMV, I start turning back slowly, and you should see the pancreas. This is the body of the pancreas, please. So you will see the body of the pancreas. This is the neck area just above the SMV. So it's actually looking very atrophic. There is hardly any pancreas. So this looks like a case of Badakaro or chronic pancreatitis. So this patient had an episode of pancreatitis in 2021. He developed a pancreatic fluid collection and a lambs was placed and then removed. Since then he was asymptomatic till about a week back when he again had an episode of pain, and the suggestion was that it is a chronic pancreatitis with dilated duct. So here you are seeing the pancreas much better. Doppler. So you see the PD is dilated in the body. Freeze. Not much, but it looks dilated. 3.2 in the body is mildly dilated. Chodo. So this is the body of the pancreas, and then you turn clockwise, you don't see the body, it disappears. This is the spleen, splenic vein. So there is some atrophy. So I think following the acute attack 2 years back, he has developed chronic pancreatitis with atrophy. Here you should be very careful to see if there is any mass. Freeze. Now this is an interesting point. See this is the stomach wall, this is the stomach wall, and you don't see the stomach wall here. See this? So this is where the stent was placed. So this area has healed by granulation tissue, and I think this is what is the thickened gastric wall, probably because of the past. See this? It's attached to the stomach wall here. See this? This is attached here. So chronic pancreatitis, microcalcifications, dots, strands. We are seeing all the findings, and he's a young patient, pretty common in India. We are trying to trace it and see what's happening. Yeah, so this is chronic pancreatitis. So this is how I do the pancreatic-biliary EUS and the mediastinal EUS. Um, Duodenum I will show you in the next case. The rest of the things I think you already know. Below is the left kidney. Above the left kidney freeze is the left adrenal. See this strand like structure. This is the left adrenal. Shoulder. And then you see now it looks like a nice bird. And then you turn clockwise and you see the spleen. So you should always look till the spleen. Look if there are any collaterals, because this patient had pancreatitis, so may have left-sided portal hypertension. Turn anti-clockwise again. Review all the things that you have seen, and I think we see the same things. This is the body of the pancreas. So that I think okay. We also see the gallbladder. I have turned little more anti-clockwise, and from the stomach you can see the gallbladder. It looks pretty okay. Those things which you are seeing within the gallbladder are all shadows. They are not sludge or anything, because there is a lot of air, as you can see. So normal wall gallbladder. So here I have shown you that from the stomach I have done almost a complete pancreatic-biliary and hepatic EUS exam. We have not seen segment 6 and 7. That can be seen only from the duodenum. But we have seen the liver, we have seen the bile duct, gallbladder, we have seen the head of the pancreas, body and tail of the pancreas. So the diagnosis that we have made here is a chronic pancreatitis, and I will again, before I come out, show you how I get this view. See this? So I am doing down and I get this tubular view of the stomach here. This is another nice way. You can go on going down like this and keep looking at the stomach. See this? I am going down. There is any lesion, you will pick it up. If you want, you can put a little water inside. So keep the tip down and you will see a tubular view of the esophagus and the stomach. So this is the stomach. As I come back, see, this is the stomach, fundus. See the water in the fundus. See, now this is the GE junction. You can see the diaphragm there. And then I come back. Again try to see the tubular view of the esophagus. See there, this is beautiful tubular view of the esophagus. The aorta is on the other side. So he's coughing. I think I should take out now.